and thanks for joining Embracing the Noise and Bias in Healthcare Data. My name is Jordan Leibnitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. This webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, but if you have any questions, please type them into your webinar console. Towards the end of the presentation, we'll have a Q&A session as well, and we'll get to as many questions as we can. But if for any reason yours is not addressed, we'll follow up with you after the presentation. So today we have two speakers presenting, Mayur Saxena, the CEO and co-founder of Droice Labs, and Dale Sanders, Chief Strategy Officer here at IMO. So as mentioned before, if you have any questions, please type them into the questions panel. And with all of this being said, I'll pass it over to Dale.
Thanks, Jordan. Appreciate it very much. Hi, everyone. Thanks for sharing your time with us. We entitled today's webinar and discussion, Embracing the Noise and Bias in Healthcare Data. And I think as we drill into the conversation, you'll understand better what we're trying to do there and some suggestions we have for going forward. It's a pleasure for me to spend time with Mayur. Mayur and I have been friends for a couple of years now. We stumbled across each other during the early days of COVID, and I was impressed with him as a young leader and thinker in healthcare in the world of data science. And I was also really impressed with the concepts that he embraced at Droice Labs when it comes to data science. And we'll talk about those concepts, including the notion of sort of recognizing the noise in data. I think is an underappreciated concept most of the time in AI and machine learning in healthcare. So in my background coming from space, defense, and national intelligence, we recognized that noise was a natural part of data. And we approached all of our analytics and data science with that recognition. And I don't think we quite do the same yet in healthcare. So I was super impressed that Mayur and his team appreciated those subtle but very important aspects of data science, and I've been attracted to what they're doing ever since. I want to emphasize I have no financial interest whatsoever in Droice Labs. IMO has no financial interest. I mean, there's a side of me that would like to have a financial interest in Droice because I believe in what they're doing, but I've purposely not gotten involved financially because I want to cleanly and without conflict of interest, advocate on their behalf because I'm a firm believer in what they're doing and the concepts that they're putting forward. There's my picture, not nearly as good looking as Mayur, so we'll get past that. And I want to plant a little thought here for later discussion. This was a saying that one of my early mentors in data science would remind us. He was a very wise, leathery old physicist at TRW, and we were at the early days of what I would call neural networks and genetic algorithms and fuzzy logic and case-based reasoning and all that sort of thing. This was back in the early 90s. You know, we were programming all of this in C and C++ and occasionally assembler. I'm so glad we don't have to do that anymore. But he would remind us when we became a little too in love with data models and forcing data into data models, he would always remind us, just let the model fluctuate around the data. And what that really meant was let the data express its relationships rather than forcing data that wasn't captured in a model into some foreign new model. So we'll go into more of that later, but just give that some thought. It's served me well over the years. Those of you who've been around me long enough might recall I used to be a big advocate for late binding, and I still am. Late binding in a data modeling perspective is still, I think, a very good approach to data science and analytics. I don't suggest late binding as a good technique for vocabulary and data standards. And so we'll talk more about all that later on. All right. Again, those of you that have known me for a while have probably seen this cartoon ad nauseum. I drew it while I was at Northwestern, and I've been carrying it around ever since. And you know, if we really want to understand the patient at the center of healthcare, We have to collect data about that patient in the categories listed in these data bubbles. You know, for the most part, we are still sort of stuck down here in healthcare encounter data and claims data, more about what we're doing to patients as opposed to the patient themselves. And then, of course, we're starting to make progress biometrics. We haven't made much progress on patient-reported outcomes. We're not leveraging consumer data. All these data bubbles are necessary in order for us to create the digital twin and understand the patient at the center. So this should become our strategic data acquisition roadmap for healthcare and understanding the patient. We've got to move out of the left side of this, the bottom side. And I use this, you know, again, one of these that I've used for years and years to describe the problem that we have with a digital understanding of patients. That's my family now a couple of years in the past up at Yellowstone on the left. And, you know, the truth is we have a highly pixelated version from a data perspective of my life and the socioeconomic factors that affect my life. So we've just got to keep chipping away at moving that highly pixelated image on the right to look more like the one on the left. This is a simple slide that, you know, I borrow from classic decision science, which is, you know, my upbringing in the military and space and national intelligence sectors. This was sort of a natural part of our upbringing and our training and the way we operated. And that is, we recognize that standardized vocabulary and terminology were fundamental to decision making. And then if those standard terminologies and vocabulary are the individual words, then grouping those into concepts are the sentences and the paragraphs and things that describe situational awareness, right? I think we all know situational awareness a little better as a concept thanks to COVID. It became a common term for the first time in my healthcare experience. We all started talking about situational awareness because of COVID. Well, we also didn't have the data to really understand the COVID situation. Then the next layer up from that is, what should we do once we understand the situation? What are some of the responses and interventions that we need to take? And then finally, monitoring what we did. Those are just classic layers in the decision science framework. We haven't nailed those bottom two layers yet in healthcare, which is one reason why images are so pixelated about patients. And this is, again, where terminology resides. J.D. Whitlock, you know, a good friend of mine in the industry, posted a good blog this morning about the need for data standards. We can define all sorts of core data elements through ONC in version 3 of USCDI, but if we don't standardize the terminology, we really will never be able to analyze data in a consistent way. We won't really be able to have an interoperable healthcare system. And here's another diagram that I'm sure those of you that have been around me a little bit have seen. You know, ultimately, these three patterns are the patterns that we are trying to stitch together to understand and treat and monitor patients. So, and it crosses patients, providers, payers, life sciences, and public health. We're all trying to understand these three patterns in one form or another. So patients like me who were treated like this had outcomes like this. And these are the minimum data categories and terminology domains required to understand these patterns that stack on top of each other. So unless we have standard terminology in each of these, we really can't ever understand these patterns very well, right? And then crossing all of these, of course, is the narrative that's contained in clinical and patient recorded notes. And also temporality. Temporality is something that we're not quite paying enough attention to, but COVID started, I think, exposing us to the need for temporality, like the onset of symptoms is critically important, the progression of disease, the timelines associated with that, and how all of that is choreographed with treatment is missing right now. We don't have a good way of describing in a computable form the temporality and the timelines of healthcare and the progression of disease. And I'll bring this up as a transition to Mayur, and then I'm going to hand the slides over to him. This is a good example of the kind of work that we need to scale in healthcare. And that's one reason I'm a big advocate of Droice. So this was a paper that came out a couple of years ago from Mount Sinai, and by using clustering techniques, they identified these very new, distinct, clinically different subtypes of diabetic patients. And we would have never seen these clusters using traditional SQL programming. I guarantee we would have never done it, because SQL is a declarative language, right? You actually are already imposing bias on data if all you do is analyze your data with SQL, because you have to construct the query, and that query has biases in it. But the beauty of data science is that it lets the data express itself. Going back to that old saying from my mentor at TRW, let the model fluctuate around the data. So, you know, it's great, right, that Mount Sinai did this. Now we've got to figure out how to make this scalable and affordable across healthcare, across patients, providers, payers, life sciences, and public health. All right. And with that, I am done with my slides, and I'm going to turn things over to Mayur. Oh, wow. Boy, Jordan, did you know that I could turn the control of the slides over to everybody that's on the call today? Aaron Niederheiser, I see you on here, friend. Do you want to present anything? Okay. I have to go down through Mayur. I got to find your name on the attendees list. Okay, there it is. You're in the middle with the M's.
I gave it to him, Dale.
Oh, okay. All right. Thanks, friend. Appreciate it.
I have not received it.
No, I see Ben Archer is the presenter. Let me try this again, Jordan. Let me try, friend.
I got it. Got it.
You got it?
Yes. Can you see my screen?
Yes.
Perfect. So I can't see you, Dale. So like, just interrupt, and as you know, where like the point of this, at least for me, is to like, you know, get a discussion going rather than just presenting. And like, I really like the introduction. So hi everyone, this is Mayur, one of the co-founders and the CEO of Droice Labs. By background, I consider myself a data scientist more than anything else. But I think, you know, I think I know a little bit about like different aspects of healthcare. So hopefully the discussion, we can make it as entertaining as possible from a knowledge perspective. See, Droice is a mission-driven company, and like it's very close to all of our hearts at Droice. Like care personalization, we think like matching patients to interventions that are likely to work for them is the ultimate goal, and Droice is focused on going towards that at all, let's say, with all the sacrifices that comes with a startup. So let me get right into it, right? So we know that in the last, like, you know, 10, 12, 15 years, 20 years, this real world patient data, or these, you know, the electronic data side around patients has exploded, and it's like all over, right? It's and as that data, let's say, you know, like came about, and as it started getting accumulated and it started hitting scale, various applications all over have come out. For inside a health system, these are some, you know, some types or user classes on the right, and this is the need, like at least the least need that we need around the patient to do various things, right? If I'm a researcher, I want to understand the patient really well. If you remember from Dale's slide, patients like me, right, then what was given to them and what were the outcomes. The patients like me, that comparison can only be done if you understand every single patient really well. So this is an example of like, okay, what do we need to understand about the patient? These are some aspects from the bubbles that like Dale was showing. So you can keep expanding more and more entities, but these are some things. Unfortunately, and I think anybody who has been in healthcare IT or has, you know, worked with this data knows this, that more or less, like we have these several pieces of information, even if available somehow in the source data sets, missing. And even if the information is there, it's very difficult to trust it because of the noise, because of the mess that this patient data is, right? Again, it's like one of those problems that like when I was doing my PhD and I was doing like working with health systems for my research and for otherwise, like it saw this like this is a nightmare. If I want to actually get reliable information, it's just very, very difficult. But yeah, this is like the basic thesis of why, like this problem exists. Talking about the current state of healthcare data, we have to talk about the pipes or the way this data comes about for these use cases and otherwise. So let's say for a use case, this like data that we are trying to bring out is here. How does it come about, right? Like no matter which health system it is, no matter what their infrastructure is, if they have a data platform or if they don't have a data platform, somehow they have centralized, crudely speaking, centralized various sources of data in its form and brought it together. And then like for the use case, there are well-intentioned, capable individuals who are then working on this data to like bring out this use case specific data for these users to use, right? Like, and if we look at how this data was centralized before this step, like, okay, from the continuum of care, this data from these various sources, EMRs, labs, claims, right? Like all the different sources and more sources every day now. All of this was brought in again by like, well-intentioned groups using tools, mostly like extraction, then transformation. So they are transforming this data into this like these structures and then transforming it again to fill this, let's say, last consumption layer for these users. The problem is that like, I think this is a very well-known data science concept. If you transform data, you risk, let's say, missing, you risk missing information pieces that are critical for this end use case. And that's like what happens, right? And that's why like you get these issues. But let's go deeper as to what, if I have to like, bring out data from this source into this use case form, what does it take? What does this person here or this person have to do to go for it, right? Like, so let's say here you are trying to build this patient profile and you have one factor, just the comorbidities, and for one condition, diabetes. It's not that all the information for diabetes is in the diagnosis table or in like some particular place in this real world patient data source. It's scattered all over, and you can infer diabetes in various ways. So if I'm a person who has to write this query, what I have to do is I have to know all the places where information pertaining to diabetes is manifested. I need to like write then a query to like bring it to this, let's say, this final form for consumption. So it could be like directly the ICD codes, it could be procedures, it could be in physician notes, it could be that, okay, the lab value is at this level, therefore it is diabetes. It could be that we are deriving it from drugs, and we all know that each of these categories, ICD codes or labs or like your notes or the various forms, there are thousands of ways in which each piece, drugs can be written thousands of ways, right? Like that's the problem. Now, as a human, if I have to write this one query that this is a diabetes patient or not, it's like I have to go through a lot. I need to know the whole database, the whole source of the multiple sources, and bring that information out. That is like, if you look at the permutation combinations, that's like an insanely difficult task to do. Just on the screen, there are like around 30-35 variables. Just to bring these 30-35 variables, there are like thousands of queries and thousands of transformations that have to happen to bring this out. This is the problem, because this data was never built to do this clinical analytics, right? It was never built for that. This is the ad hoc, let's say, process that we have to go through. This process that we were talking about, it creates this incomplete, let's say, result at the end. If you compare this to what Dale was showing, yes, the original patient is like, in the full data or the full reality of what it is. And what we capture, the point of production itself, it's just, like a very small, it's like an imperfect mirror. That's at least how I think about this. That's what, you're capturing in these data sources. But then through this process, because of this noise, because of this bias that we just spoke about, right? Like here, that data is all over. This was never intention for this. This picture, whatever best picture we could get, the maximum information we could have gotten, keeps getting blurrier as it moves forward in this, let's say, journey of data from the source to this consumption part. So yeah, so that's like the basic, issue, and we all struggle with it. This is a little bit of like, this is my viewpoint, or let's say a bit controversial maybe, like, but this is the healthcare industry overall, this whole industry, right? Like for this manual process or like semi-manual process, if you have a data platform, semi-manual, if it's like you don't have a data platform, it's like, totally manual process of bringing data out. now it's a cost, it's a resource drain like on these health systems to do something. And even though you get like this inferior net product at the end, it might be worth it in some cases, it might not be worth it in some cases, right? So what happens because of this poor data output? What happens is, like, for financial cases, this is a very common case, right? Like, you're missing revenue. Okay, we didn't know all the comorbidities, we didn't know all the risk profile of this patient, and now we have underbilled, or we have overbilled, or we've incorrectly billed. And now what's the solution? Let's put more people. The health system's own people, or outsource it to a third party, or outsource it to a data platform or a data vendor, like of some form, or data processing vendor to do this part, right? But because it's revenue, because it's like this healthcare finance, like one of the major cases, even putting more people, return on investment wise, okay, net positive, let's do it, right? Like, okay, worth it. Operational things, now it depends on which operational things we are talking about. This is missed revenue, of course, and also inefficiency, right? Like the basic challenges that come about because of this part. What's the solution? Let's put more people. Why are you putting more people? You are just going back, okay, we got this product, I don't like this, I don't know, understand this, tell them changes, they go back into this setup, get more data. It's iterations. You just keep doing this more and more manually, through queries, through people chart reviews, whatnot, right? So just putting more and more people to make this happen. Now for operational things, again, this might be worth it, might not be worth it, like depending on which operational, like, feature we are talking about. You come to research, like getting the requirement in research. If I actually want to do clinical research where I need to understand this patient for care, and I need that high resolution, precision, and reliability and traceability and all those things, like, it's the number of people and the amount of effort that will have to go to this process to make this like worthwhile is insane, right? So it's definitely ROI negative. The result is we don't do it. We just don't do anything about it, and that's the situation. Care personalization. If I'm a doctor and I'm trying to understand what Dale literally was showing, right? Like, were the patients similar to this patient? What was given to them? What were their outcomes? What worked? What did not work? I just want to know that to take a better decision for my patient. Now, I can't do that because, again, same problem. Lot of effort to get this going. Again, a semi-manual ad hoc process. What ends up happening? You don't do it. And also, like, there's a healthcare policy aspect to it, right? Like, you all know the misalignment of incentives of metrics or benchmarks versus real patient care or patient outcomes. Like, you just don't do this part. Dale, anything you would want to debate here?
No, not really, friend. It's I think you're onto something here, and it reminds me of a slide that I sometimes use that shows, if you're going to affect healthcare, you have to think of clinical and research operations. Then above that, you have to think about the economic incentives of clinical and research operations. The economic incentives for an academic medical center are quite a bit different than they are for a community hospital, for example. And then above that is the regulatory and compliance environment that drives a lot of the economic incentives. And so, I worry sometimes that the economic incentives for payers and providers, they don't really care about data quality yet, right? But now life sciences definitely does, right? Life sciences has real economic incentives to have better, faster, cheaper products, and data drives a lot of that. But I worry that in the payer and the provider space, the economic incentives are just not there yet. And of course, then that sort of implies that we've got to do something about the regulatory and compliance environment to drive different economic incentives. What do you think about that?
No, I totally agree. So when I was making this slide, this was like last night, right? Like before this question mark, I had a 0 here. And like, and I was like, maybe that's like a bit insensitive. Maybe it's a bit harsh on the whole healthcare, like, system mechanics, but unfortunately that is true, right? Like that there is, what is the incentive? So what has happened is, in the name of value-based care, we have these metrics and benchmarks, right? Like that's what the market has taken. And we are reporting that, right? And now even doing that is so much effort that like we need to put like more and more tools and more automation, more and more people on this. And unfortunately, that is like, it's the debate. Does it really impact patient care, right? So that's like the always going on debate in the background. So
I mean, sorry, friend, I'm going to interrupt for just a second before I forget. I mean, I do think there is hope on the horizon, like Medicare Advantage, for example.
Yeah.
You know, there's real economic incentives potentially in improving care through Medicare Advantage if you're working on a capitated model. Integrated delivery systems like Intermountain, they have a genuine interest in, you know, better, faster, cheaper products because it ends up with margins for the insurance company. So, you know, things are happening. I just wish they'd happen faster.
No, I totally agree that eventually Medicare Advantage for all and Medicare Advantage in itself, like being a fully capitated to some extent system, I agree. But if you look at even Medicare Advantage, like in like these two layers as to who's the bidder, and then the billing with, let's say, the individual health system, it becomes fee for service between the Medicare Advantage, let's say, the bidder and this health system, right? Depending on so if you look at like the detail, most of the revenue, even in that fully capitated setup, between the health system and them is like actually fee for service.
Right.
So yes, it's happening. At least it's a move in the right direction. I also wish it was sooner, but that's what this convergence is about, right?
I wonder if we could, you know, I wonder if we could change our quality measures so that they're not so much about quality of care and these process measures that we have right now, but what if it was about measuring quality of data? And adherence to data standards, because then if you think about it, if we incentivize and we paid healthcare systems to standardize their data and use standard taxonomies, you can repurpose that data for just about any use case, right? Once you have high quality data. So, you know, maybe that's something we should start advocating, is that we introduce, we kind of introduce data interoperability and data sharing as incentives under, the High Tech Act and meaningful use and all that. But we didn't talk about data quality and data content.
Yeah.
Interesting.
I think the whole idea of quality, right? Like in general, data, not talking about just healthcare. Data is what data is, and quality is dependent on the consumption part. How are you going to use it, right? Like, and if we are using it for benchmarks, then quality has a certain definition. If you're using it for improving patient care, then quality has a different definition. If you are using it for like, a operational thing, then quality has a different definition. So to me, it's about like, incentivizing. So like to actually make things happen, it's about incentivizing the right use case. And as you pointed out, Medicare Advantage are actually like improving patient care. And then like all of these, let's say, behind the scene processes get organized. So quality, then we have to worry about building an accurate profile, because we can't really scale good care without bringing up these, let's say, top-down care personalization engines, right? So to me, it's about like incentivizing this use case, and then the rest of this just like fits into that, because healthcare is mostly, I mean, if you look at anything, right, like in healthcare, like it's mostly a compliance market. And most of healthcare data analytics is also mostly compliance market. Again, that's a very particular viewpoint, but if you disagree, like, please correct me.
No, I think it's an interesting way to describe it, friend. I mean, if you think of what drives healthcare change, it's mostly compliance and regulatory, right?
Yeah.
And then there's usually some economic, sub themes to that, but it's really about complying so you don't get penalized as opposed to being rewarded,
Yeah. So in this care personalization part, to your point, right, like Medicare Advantage, you make that capitation real, right? Like, and like 100%, which I don't know that can happen, but like, then yes, then I have to do everything. And when I want to see like what's working, what's not working. So yes, it's moving in that direction. It's like always about like incentivizing the right things and making it happen. The point that I want to make sure that the audience gets is like, it's not because that this process is inherently like, bad. It's because of the noise in this data, right? It's this noise that we are talking about, this bias that we are talking about, is the real reason why this system is inadequate. And second reason is that now this consumption layer has become very big. People have started actually finding value in this data source, and therefore the requirements, like, will this process like, deliver on this growing appetite on this, like, let's say, analytics layer, this researchers layer, executive layer, like clinician layer. That is not like, if you look at other industries, that's not how they are going about this, right? So coming to the next point here, if we had to build a system, right, like if we had to build a software to actually connect to these various devices, like various sources of data, and then spit out this high quality data, or let's say this very accurate patient profile, if we are, and which can then be rendered right through Fires or OMOS, but you need to actually maintain the high sanctity or the high reliability, let's say, profile of the patient from the source to this post this pipe, and no transformations, right? No loss of information. What do we need to do that? Sorry. If you had to do that, what would we need here, right? So if you look at that, it's first of all going back to this very specific problem, if an engine instead of a human has to go in and find all the information pertaining to diabetes, this engine needs to know where all that information is manifested in all the various ways it can manifest, right? So I need to know the various ways it can be written in notes. I need to know the various ways different labs can indicate that, different drugs can indicate that, the various ways written, the various places it's in this source of data and whatnot, right? So that's requirement one, for this engine. Requirement two is that it needs to scale across. Every source is different. Every source has its own noise. Every source has its own bias. It needs to scale across these sources, right? And the different noise and bias structures that exist there. Maximizing information, that's the principle, that we need to get all this information to get a holistic picture. And so, okay, how do we achieve these things, right? To get to, so this is a very good AI problem, actually. If you look at it in piece, that intelligence has to come out to which recognizes elements of information, categorizes them, and brings them out, right? So for machine learning or for an approach like that, you need massive volumes of data to actually make this part. I'll pause here. There are other points here, Dale, but I'll pause here if that makes sense. Any comments from you?
No comments, Ren.
Okay.
I'm anxious for the audience to see your demo. Are you at a point? And
yes.
I don't want to. I think. Well, anyway, keep going, friend. You're doing great. Yeah.
No, fine. So these are the aspects, right? So you need to work with a lot of data, a lot of scale, and these are the things that now technologically are possible considering different fields. And that's why what Droice does is we are the ones who are building this software system that can connect to this, make all of these data flows come out, and then bring out this very deep profile for various use cases. And to your the ask, right? So this is what Droice Hawk is, and I'll show you a portion of it in a second. Coming to this, this part. Okay, so if we had this profile, what can we do about it? This is where this what you were showing about the clustering and whatnot. In a lot of ways, if we can take let's say very deep profiles about the patients, and then we can do a lot of this, let's say, breaking down of these patients of population, whatnot. So let me just go to the demo, and I think we can talk about that in detail.
While you're starting the demo, friend, I'll add, the beauty of purist data science is that you can start generating situational awareness and hypotheses from noisy data. And I know that sounds kind of cliche to say that, but I think a lot of times with declarative programming, we are assuming more truth in the data than what exists. Whereas data science just sort of recognizes it. And so over time, as you add more precision to the data on the left side, the data sources on the left side, the clusters and the situation become clearer and clearer, right? Mm-hmm. But you're still able to generate sort of meaningful hypotheses and situational awareness from those sort of loosely defined clusters, right? That's what the human brain is really good at, right? So yeah. Okay, so keep going.
No, I think to your point, right? So just for the audience, so what I'm about to show on the screen is it's all real data, has been anonymized, so there's no re-identification risk here. I'll just let this play for a second. So this is data from one health system, I think 2 or 3 hospitals, around 30-40 clinics. These are all their CKD patients. That's the whole population. What you're seeing on the screen is each dot here is a patient, their structured data, their unstructured data, the various sources of data that has been that was connected through the software that I was talking about, Droice Hawk. And then you spit out, right? What Hawk has done is generated this deep patient profile. And then we used a very basic, one of the most basic algos, just clustering, basic clustering, to break it into these groups of medically similar patients, right? As to Dale's slide, like that, who are the similar patients. So each color here is representing each of these groups. And then like
So these are CKD patients with these comorbidities, essentially, right, friend?
So I won't, so that's exactly the point here, right? So the system is not deciding that are these comorbidities or are these not. The system is just breaking it down into these subpopulations of similarity. Now,
Yeah, okay.
right? And that's what it is doing. And now, like when we go in with doctors, with like several people, and then we go in and look at, okay, what is this group? What is this blue group actually? We found that it's actually nothing but the whole disease etiology of this like CKD in this case, and like the paper that got published was a heart failure. That okay, the whole disease, the well-known, well-understood disease etiology that has been developed over years, that whole thing got reproduced in a completely unsupervised way in this process. So to your point, the earlier question the point that you mentioned, right, that what is data quality? To if this let's say this pipe, right, this Droice pipe is bringing out good medically important information, right, like from the source, this messy, noisy, biased source, and spitting out medical, let's say, disease research grade, regulatory grade disease etiology, you're doing the job, right? That's a way to test if this product is actually, like, this pipe is actually bringing out the right piece of information. So this publication of this work, or this, let's say, this whole idea of breaking this population down is to show that you can reproduce the whole disease etiology without any supervision, without any input of, like, domain, and make this happen. I'll pause here.
Yeah. There's no way you'd model this with declarative programming. No way, you couldn't do it. So once your models reveal these clusters, then you bring domain experts in for the labeling, right?
Yes, for the labeling.
So there's some interesting things there that go on, but the vocabulary they use to describe these subtypes is interesting, isn't it?
Yeah, and I think, see, that's why I disagreed with, like, are these just comorbidities? No, because we find subpopulations that are hybrid comorbidities, and they're completely novel, right? They're completely novel, and we don't know, they behave differently. So I'll just actually let this play, and, like, then we can keep discussing this part. What you're seeing on the screen for the audience, like, is the whole population strata broken down into these subpopulations, because Hawk could generate this great, let's say, detail, whatever. And now you're looking at all the various characteristics. So just like to make the point, right, these things cannot be even getting to this measure that, okay, this particular drug or this particular, let's say, comorbidity, this is at this percentage in an accurate form. That itself is very difficult, right? So that's like, forget like personalization, forget like breaking it down into any subpopulations. Now, so this normalization, this harmonization of data from various sources to make this outcome measurement, right? Like, why do we go to benchmarks? Because we can't measure real outcomes. It's just not reliable to measure real outcomes at scale, and that's why we stick to like benchmarks and comparatives, which are easy to calculate. So right, so that problem, because of this completely new way, no ETL, no transformation, just parse this information and like make this whole thing happen in a very, very accurate form. No loss of information is making you is enabling you to measure the right things first. That's number one.
And I think it's important in your data pipeline, you didn't load this into Fire or OMOP or Odyssey first, right?
Absolutely not, right? So this is if you look at the Hawk part, like, we are connecting to this, we are not transforming. There's extraction and then measure. There is no transformation. Like, of course you're loading it, but like, there's no transformation. There's no, let's say, sequentially bringing out any information. That's what preserves information. The idea of maximizing information, you can keep enriching it and enriching it, and you can keep getting a very, very detailed picture. And then you can put it into OMOP, then you can put it into Fire, then you can put it into data marts, depending on this live use case. And this is not just Droice's approach. If you look at finance, if you look at Google, if you look at Facebook, that's how they work with data. They are not doing ETL behind the scenes to like serve it across the enterprise for various use cases for the massive data that they are working with.
Yeah, it's interesting that, and again, this kind of goes back to my upbringing, many years ago, is that you modeled the data after this. Yes. I mean, or you stuff it into a data model, maybe I should say, after this, right? Whereas in healthcare right now, we're stuffing it into a data model, then we're analyzing it. But when you stuff it into a data model, that the data may not have been collected under that constraint, you're messing with the truth of the data, right? Yeah.
Exactly. And like and this should be dynamic. the cost of like if you go through ETL, the cost of filling it into OMOP or into like a Firebase like data model or Firefeed like is very, very high. So you do it once. Whereas in this case, when you have a streaming setup, you can fill this dynamically for this use case, right? I can put this portion of data model for the other use case I can put, and this is how you embrace, this is how you deal with the noise and the bias by localizing it for each use case. And that's what this software is doing.
Right. Do you have a way of tell me how you deal with temporality and like the progression? I mean, the truth is temporality is a data point that's pretty hard to recreate in healthcare data. But do you have anything that shows the progression of disease?
Absolutely, that's like the bread and butter for us, right? So I'll just go into this more, right? So you have this. So now what we have done is we have gone to one subpopulation, and now we are finding that okay, these are actually this subpopulation has subpopulation, right? So and there's mathematical, let's say, resolution here because we extracted so much information. You can keep going deeper and deeper into each of these subpopulations, right? And
it becomes a fractal, a Mandelbrot set or something, right?
Exactly. So you maximizing information. Why does it matter? Because now I can go and say, okay, for this whole subpopulation, let's take chronic lymphocytic, whatever, let's say type 1. And now I can define care for this particular group and target it, right? Because they behave differently. Coming to disease progression in just a second, right? So you have gone to this like one subpopulation, you're looking at the whole outcome chain, you're looking at the various things that are happening there. You can traverse your whole population. This is completely unsupervised, right? Like it's not like you can actually understand what is happening to various subpopulations in terms of their behavior, in terms of their profile and whatnot. Coming to the dynamics in just a second. So now you go to one patient. Of course, the temporality is like the biggest part and progression goes from there. Now you can understand, see, what's the problem of temporality? The problem of temporality is that if we say that, okay, we are going, what's the finite point when disease has now moved from CKD stage 3 to CKD stage 4? Like, that's really not clear as to like, what is that spectrum of progression? It's not clear. Now, in this unsupervised manner, and this is like completely condition agnostic. So what we are doing for CKD, we have done for heart failure, we have done for leukemia, we've done for all sorts of conditions now with all the like, hundreds of like hospital and like pharma that we are working with. So now what you're seeing here is like, as you go to one patient, you can start seeing how these patients hop across these essentially physiological states as their disease is progressing. Sometimes they will be stuck in this, let's say, transaction, and then over a year, they will move to another transaction, right? So this is what this dynamics part. Now, what you have done is like, because you have harmonized it, because you have normalized this, you don't need to put in that, okay, has this patient progressed from a doctor and their subjective judgment. You can actually do it quantifiably across the whole population. I'll pause here.
What are the arrows? The arrows indicate progression and path, right, friend? But how does that relate to timeline?
No, so again, right, so timeline is here. So you're moving from gout to this, right? So this is what is happening here. And it will be different for different patients, right? However, for this whole group, you can find that average. So now think about it, right? If you're looking at progression earlier, if you said, okay, even if you knew that gout patient somehow moved to insulin dependent type 2 diabetes, first of all, that is not known. People don't know that part, right? Like that, this is what is happening in my practice, in my subpopulation, because this is not a global pattern. This is a local pattern. This is a local pattern for your population, for your patient type, for your care type, for your system. So let's say even if you know that, now for me to like, okay, define a protocol or something, this duration, this is a 6-month duration. Now that average, if you average this across the whole population, you will get a different average than if you average it now for this localized population that Hawk has created. So you can define much, much, much better and more targeted, more effective protocols to actually improve care.
How likely is it that you can find patients with a similar progression of disease that have a progression of disease map that looks like this? How likely is it? How technically possible is that, do you think?
So you mean like likely as in all of this, like all the 4 transactions, or just 1 transaction or 2 transactions?
Well, for Susan Vitucci, right? How many other Susan Vitucci's or sort of approximations of Susan Vitucci's progression of disease? How scalable is this as a pattern?
No, yeah, so understood. So basically what's happening here, right? Like in this particular pattern, each of this state, let's say this gout state, let's say type X state, will have like 2 or 3 progression curves. So it's actually like so like 30% of the patients here will like go into progression curve 1, 20% will go here, and that's actually like the next paper that is like, you know, in review, which is like saying that, okay, these are there are 2-3 ways in which they are progressing. Now you can start targeting each one of these ways. So it's actually very actionable from a volume standpoint.
Yeah. Okay.
So it's not like you will have each pattern, a unique pattern for each patient. It's actually very like there's a pattern to it. There's a group that is moving in a certain way because of the disease type they have been like able to come up with. And proof is in like this whole reproduction of disease etiology. We already know, even if you remove all this, even if you remove the data-driven part of this, we already know that certain types behave in a certain way. What Hawk is doing is now it's like localizing that general knowledge to your practice, to your patient population, to your, let's say, intervention curve, how is your population subset moving in different directions.
Yeah. Gosh, yeah, it's really good, Fran. Every time I see a new version of this, it's just really interesting. You're hitting the right concepts.
So yeah.
We've got like 15 minutes or something.
Mm-hmm.
It would be fun to talk to the I don't know if we have any questions. Do we have any questions, Jordan? Let's see here, Fran.
Yep, there's definitely a few.
I haven't, let me see here. Oh yeah, boy, there are a bunch of questions. I wonder if in the questions, I wonder if there's an opportunity to talk about. So here's one of the concerns. Like I'm talking as a business person now, right? Like maybe if I were going to invest in Droice, I would ask, wow, you know, there's a lot of data platforms in healthcare now. That's the good news. But the bad news is, so what do you know, switching costs are hard, right? And so, you know, I'm kind of curious about, I'm curious about how Droice functions within the ecosystem of an existing data platform.
Yeah, and I think like the the part there is that the way we are looking at this is when the current process, the current data platforms are serving the use case well, whatever that process, of course, it can be better and whatnot, but like it's a certain setup for these use cases, which are actually like real population health management, right? Like real care personalization, research, right? Like for these use cases, the current platforms are unfortunately lacking, right? So we are not saying that replace your data platform and use this. We actually have figured out a way to like work with these data platforms, feed into that, right? So I mean, let me see if I have this is an example architecture, right, for a client that like your data platform environment stays as is, and we are feeding data depending on like, so we are enabling these, you know, like this clinical use case and these research use cases, which is where these platforms struggle a lot, right? So this is an example, right? Like not the only way to like make this happen, where if you have I won't take names, but like a famous data platform, we can feed into their own structures, and you can leverage
a platform like Health Catalyst.
You said it, but like you can feed into that very easily, right? Like and because of their, so what's the challenge there? Challenge is that what are they offering? A data platform like Health Catalyst, what is it? It's offering tools to make this like this whole linear process or human process like happen one by one, right? It's giving some level of automation and scalability and infrastructure to it. And so there's a lot of good stuff there. Like, don't get me wrong.
You know, something that just crossed my mind, friend. I don't think we've mentioned that you're bringing in categorical and free text data.
Yeah.
Those clusters are being fed by clinical notes as well as categorical data like ICD, SNOMED, discrete data like labs, etc.
Absolutely. I mean, the most important, so free text data, if you're measuring an outcome, an outcome is a composite of free text data, structured data, unstructured data, abstractions, all of those things, and then you can measure an outcome. Then you can measure a comorbidity. So Hawk is going through free text data. We are like, you know, this, like we are working with like data of more than 100 hospitals from US, Europe, right? Like, so we work across languages, we work across like IT infrastructure, across EMRs and whatnot. And that's the point of doing Hawk. It's like the true big data that is needed to make this happen. So not at all trying to replace the current platform. Like we are actually like very, very synergistic in a lot of ways, because we are improving the quality of the data that is like blocking use cases that are just like, that were not possible with the current, let's say, infrastructure and the tooling that exists. It's a new tooling layer, and just bringing in like very, very strong data science plus software engineering principles to make this happen.
Yeah. Yeah, the challenge with, going back to Health Catalyst for just a minute. I mean, we built Health Catalyst at a time when a lot of these data science techniques were fairly immature. The cloud wasn't as mature, and it was really, heavily influenced by traditional relational databases and declarative programming and that kind of thing. And so, yeah, this is very interesting. So option one is you say with Droice, you're helping fill the traditional data model, clinical data model, through the output of your data, but not all of it. I gather that is that pink? My color blindness is showing up here. Is that pink?
Yeah, no, this is internal. So we don't want to, and we cannot fill the whole CDM, because, for example, the operational things and the financial things and the metrics things, there is a workflow. Like these data platforms have been able to create a workflow and use that. However, for this
very much rules based, very much rules based. Yeah.
So leverage, and that's good, right? Like it's serving a purpose. Benchmarks, not necessarily patient care, real patient care measures, right? Which a physician is looking for, or researcher is looking for. So that like high quality, high fidelity, high reliability, high traceability stuff, we can put it into your CDM, right? No problems. We can put it into a data mart. Yeah.
So when you normalize data to a data mart, what does that mean, friend? Are you normalizing the vocabulary? I don't know that I've ever asked you this question.
So for example, like this diabetes example, right? Like you can leave it at the level of, okay, we have gotten, or we have collected, or we have parsed all the information pertaining to diabetes and we have brought it in one place. Or you can use a normalization engine, or like normalization, let's say, vocabulary. For example, like some of our clients have used like systems like IMO, right? Like you can use that. Okay, we can put that in. Sometimes they have their own definitions, right? Like especially like if you look at the like the research side, they have their own definitions. And so what Hawk is doing, it's absorbing it. Sure, just tell us, like, and it just goes and parses it. Yeah.
What are you using for master reference data to normalize to? Are you accommodating? So you've got to accommodate ICD, SNOMED, RxNorm, blah, 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 all that kind of thing. What about local? What's your ability to ingest local taxonomical definitions for like cost centers or something like that?
That's the most common case. I think you know this, and I know like because they always have been curating their own essentially ontologies, their own vocabulary on their own rule sets, and so is a system which can absorb this essentially value set, right? Like crudely speaking, value set, and you can just implement it with very high precision on this noisy, messy data. So we just take it from there. So a lot of our implementation, that's what we do. We collect all these definitions of whatever they have, and they really want it. And we just implement it really, really well, because we are not like we are doing essentially a streaming rather than like you're transforming the data, when like implementing a variable becomes very, very difficult.
Yeah. This is a bit of a random but related question, friend. If somebody from the Google Brain team peeled apart your data science infrastructure, would they see anything particularly novel? Or what would they see in your machine learning data science environment?
So I think the most obvious mode for Droice is the massive data that we sit on, right? We sit on tens of millions, if not hundreds of millions of patients' raw data, and we have product development rights. As I said, like for us to build Hawk, to be able to do this, you need these different aspects, right? Like you need to understand noise, you need to understand the variability, and that's what we have. So when we develop this, we are a Series A, like it's like 40-50 people company. Our whole business development tactic has been that let's go and touch as much data of as much variety and get to use that for this product development. And that mode is what we saw. First thing that our Google person will see that. Second thing they will see is like actually like they will be a bit sad that really in healthcare you don't have these, let's say, architectures like still. So that will be, they will be happy with it. And then like So it's a combination of software engineering, it's a combination of infra, it's a combination of data, it's a combination of data infrastructure, and then data science principles, right? And data science itself. So no, there's no like one particular algo or one particular model that like, oh, what a new model. No, that's not the point at all, right? The point is that can we go end to end from source to this end consumption layer, maintaining and maximizing this information gain across this whole pipe to make this use case happen. And how can you do that across systems, across geographies, across IT infrastructures? How can you do that? And processing these millions of patients a day or a week that we do, like across unstructured data, free text data, structured data, it's not easy. There's a lot of engineering that goes into it to make this platform work.
Yeah, well, it's funny because the truth is, I mean, I don't mean this to sound like the old guy, but the truth is the underlying concepts in data science haven't changed much since I was exposed to it. But what has changed is the availability of data and the computing horsepower to run more and more iterations and more models, right? I mean, that's what's really changed. But the k-means clustering and random forest and all that, I mean, it's all kind of basically the same old stuff. But okay, you know what, friend? We haven't answered a single question. I'm happy to stay over.
Yeah, I'm fine with me. Totally fine with me.
Okay, well, before we lose anyone, I just want to thank everybody for attending, and thank you, Mayur. This has been a lot of fun, as I knew it would be. Although we agreed to disagree and debate on a few topics, and we haven't done that yet. So, all right, let me pick a couple of questions. Keegan Bailey, dear friend, is online today, and he asks, isn't situational awareness a cornerstone of public health practice, thus health and healthcare? I think is that a rhetorical question? I think that's a rhetorical question, Keegan. Yes, friend, it is. I mean, situational awareness. I mean, we just saw it. Now we're all sort of amateur data scientists thanks to COVID and amateur epidemiologists, and we're clueless about situational awareness. So that's what I thought I was going to bring, from the military into healthcare, and so far, I haven't really done a whole lot. Okay, Gary Dickinson asks, critical missing data includes complete provenance. USDDI only includes author's organization and timestamp. That's an interesting point. Yeah. Mm-hmm. Critical missing data includes complete provenance.
Sure.
USDDI only includes author's organization and timestamp.
No, yeah. I think if I understand correctly, you need a lot of metadata. You need a lot of metadata to this output. So I'll give you an example, right? So for example, if I'm a physician and you're telling me this patient is also similar to these 100 patients and this is what is happening, then I need to be very sure that this patient is actually this. So how will you give me that trust? You can give me a quality metric, you can give me this mathematical measure, you can give me that mathematical, I don't care. The only way you can trust is okay, if you show me the source and your inference logic, right? Okay, is this rare? And you need to give this at scale whenever and however, whenever you want to make an inference, right? So it's this evidence, basically what is the supplied evidence, and we put that in metadata, right? So when we work with life sciences, when we work with especially people in research who really care about high quality research, they need this metadata to trust anything. Otherwise, okay, it's just one more thing that you have just told me. So totally agree with the point, need very high amount of metadata, and that's our business. That's what Hawk is doing. That's why, and think about it from an ETL perspective. You can't generate that metadata if you are just doing SQL transformations and reproducing that. I'll pause there if that makes sense.
Yeah, I like that. And I'll my background in military and national intelligence data provenance is super, super important to decision makers. Right? An intelligence analyst never delivers an intelligence assessment to a decision maker without describing the provenance of the data that goes into it. It's just a natural, embedded, expected part of the military and national intelligence communities. But we don't quite have that yet in healthcare. Sort of the face sheet, the metadata that sits on top of data that says, this is kind of where it all came from. This is the reliability, the sources, human intelligence, signals intelligence, all that kind of thing. Okay, let's ask a couple of other questions here. Aaron Niederheiser, one of the smartest people in healthcare data. If you don't know Aaron, you should know Aaron. By the way, Mayur, I don't know if you guys know each other. So Aaron says, very cool. Are you doing any normalization before clustering? For example, one patient has a lab component called white blood cell count and another has a lab called WBC. If you don't normalize before clustering, how does clustering understand these things? Yeah, the same thing. Yeah, right? That's a great question.
No, we are not.
And that's the problem with a lot of our vocabulary in healthcare right now, is that makes that a big problem.
No, so the way I see it is it's noise, right? Like it's noise, nothing else. And no, first of all, for this publication especially, and for this like particular application, we're not. In some cases, like for example, our clients want to see or want to do some normalization for the exact reason, Dale, that you had mentioned, that they have their own rule sets or their own ontology and their own use case. So there we have to, for a customer, we do. But from this paper perspective, no, absolutely not. We don't do that, and we don't need to do that. That's the more important part, right?
Yeah.
And why?
Well, and there's sort of some danger in equating white blood cell count to WBC. There's some danger in doing that a little bit. But if you just kind of let the data express itself and you see these different clusters and then you drill into it with a domain expert and you say, look, WBC and white blood cell count I think they're the same thing. Then you kind of go back and you clean up the data, right?
If needed, right? Like the point is that this is noise. This is just noise, right?
Yeah.
If we went bottom up and we started making these rules, right? Like that this is correct, this is not correct, this is actually for diabetes, this is not for diabetes, then that is like a humongous task that will never happen, never scale, and that's like the problem, right? So now what if you don't need that normalization? What if you don't have to do that, right? And let the data just like tell you what are the various subtypes, and then if you think a subtype, then I need to go to every patient and make a protocol, and I need this white blood cell count to be at this level for this trigger in my protocol to happen, then yes, go clean that data, and then you will need that parsing, right? But that's a very, very specific use. You don't need to do that for all your data to do 100 other things that are just stuck now because people are just doing the cleaning part. They're just stuck with that. Unfortunately, in healthcare, most are like they usually just clean this data, which is like
Well, I always say there are two things I have about normalizing data. First, it's sort of a necessary evil in healthcare, unfortunately. But normalizing data is actually abnormal. And we, there's a saying that I picked up when I was in the chip manufacturing, Intel manufacturing space, that I think came from Andy Grove. And the saying at Intel was, stop optimizing something that shouldn't exist in the first place.
Exactly.
And the truth is, normalizing data is one of those things that we shouldn't be doing so much of. We kind of have to right now, but it's a symptom, not of a problem. Okay, let's ask another question here. Anu Srinivasan asks, instead of rewarding for the processes, I would assume that's probably economic incentives on quality measures or something, it would be worthwhile to look into outcomes for any patient condition to see all the effort spent more worthwhile. It's a much bigger challenge, however, due to non-standard clinical description of the various medical conditions. Yeah, well, exactly. I knew we're not even collecting outcomes data for the most part. And talk about the wild west of vocabulary and terminology. We don't have any standard terminologies for describing patient outcomes. So it's on the path of data and digitization maturity in healthcare, we've got to move into patient-reported outcomes with standard vocabularies.
So Dale, I have a slightly different perspective there, if that's
a disagreement.
So I don't think that we are not like collecting outcomes, and I don't think so. Of course, we are not collecting all outcomes. Of course, like there are certain like outcomes which we do have no information about, and no doubt about that. And yes, we should collect more information, and that's what is happening on the source side, right? Like more and more information is being collected in various ways and various forms. Does the current data not have outcomes? I don't think that's true. I think there's a lot of the problem is you can't rely on the measure of the outcome you come up with. And that's the problem, right? So if you can actually calculate these outcomes and disease progression, break down disease progression, not by CKD stage 3, 4, 5, but actual real patient physiological multidimensional disease progression, which is how like pharma has done research for decades, right? Like it's not a new concept. Right? So normalization is actually, it's not a bad thing to do normalization. Pharma has been doing that for clinical trials for decades, so it's for hundreds of years, right? So it's not hundreds, but like for a long time, right? So it's about how you do it. It's about what is your control. It's about, can I trust this can I trust this measurement of this outcome?
Right.
right? It's about the evidence chain. It's about the audit trail. It's about that noise. Did you handle this noise? Did you take care of this noise? And I think the question had this part, right? It's variable. It is variable. And that's a way of bias and noise. Now your software, why, but it's variable. How people write Twitter, like, like posts, people write like various things in different directions. We can take care of that. Why can't we take care of this? I'm not saying everything is possible, but a lot is possible.
Yeah. Okay, a couple more. Yep. So, and I'm trying to sample everyone's questions here, friends. Thanks for submitting these. Ron Rabitsky asks, how do you assure semantic and temporal integrity across multiple data sources?
It depends on the use case, right? So that's a very good question, right? Like, for example, if you're using it for a researcher versus if you're using it for a clinician versus like different types of, for example, a primary care physician versus, let's say, a heart failure or cardiology specialist will have different meanings completely of what the disease is, right? So, and then what the disease progression markers are and what the disease progression understanding is. So the way we deal with it is that we say, okay, fine, like either you tell us what you want or what you believe in, and it's Hawk's job, Droice Hawk's job to implement it with all the accuracy and precision that like the software can do or what it deserves, right? Like and then give that evidence chain back to them. So integrity is like, is, again, it's a use case dependent thing. For a lot of these cases, for example, when we are showing you these clusters and this whole thing, you don't need that level of, let's say, bottom up every piece matching every piece. That's just noise. You can deal with this noise if you use this appropriately. So you very use case dependent, and depending on which part of this like, use case you are in, you might have to put in, let's say, additional effort, or you might not have to put in additional effort. And what we have seen is that if you are able to think about it like this, like if it's easier to integrate the data for 10 patients versus 100,000 patients, right? Which 10 patients are those where I need to do this? That can be answered by this top-down approach and this high quality data, the maximum information that we can generate from this data source, and then take it from there.
Yeah. Yeah, this is kind of reminding me of a related concept that, and that is the essence of data science is actually being wrong first.
Yes.
Not being right. And being right too fast, too soon with models basically means you've overfitted. But a lot of there's a rush to, AROC scores and things like that. There's this rush to being right, and there's this pride in being right with data science. But the truth is, being wrong is more important to good data science than being right is initially. And eventually you want to get to being right, but you kind of want to be wrong with semantics and temporal integrity, and then you go through this journey of improving your data content. Really, is what it amounts to. But in the meantime, you're getting value out of the output.
And see, it's like wrong is inherent to noisy data. It's called error. Right? Like you will always know, even if you put a human being to go in and stitch data to the best of their capabilities one by one, and you give them 100 years, there will be error. And that is true for any system, right? Like, and so error, it's about embracing that error. What can we do if we can, if this is the error, now what can we interpret here? It's about, it's answering that question. And now, okay, we got to this 20 patients, 30 patients. Now we need to like reduce this error. Because
and there's strategies for reducing the error, right? And then you just need to be aware of that. And that's one thing we don't do well. We don't recognize, we put p-values and confidence boundaries and things like that around analytic output, but that's not the same as this. This isn't. It's different. Yeah.
I mean, if I'm trying, see, let's take an example, right? In the CKD population, I'm trying to, let's say, localize, or let's say I'm trying to start now personalizing the care for this subpopulation. Okay, my protocol will be different for this red group versus the blue group versus like whichever group, it will be different, right? Okay, fine. Now I go deeper into like the subpopulation. I'm just targeting this subpopulation. How many patients am I getting? And like, okay, we can flag the cluster or wherever they are. And now, okay, for this patient, we need to verify. Now you're verifying one patient instead of 11,000 patients in this like particular time period, and that's the point. You have now made a completely unscalable problem into a very scalable problem, and you have been able to deal with noise.
Yeah, I would say a manageable and an aware problem too, right? I mean, that's the important thing: aware and manageable, right? And then that becomes scalable. Yep.
Mhm.
Okay, let me pick another question here, friend. Let's see here. This is from Rourke Yeakley. I think you know Rourke. Can you talk briefly about overcoming the resistance to using unstructured free text data?
I think, I mean, Dale, this is my viewpoint. What I've seen is that people worry a lot about using the, like they question the unstructured data a lot more than what should be proportionately asked for the structured data. So there's a
Right.
lot of mess in the structured data that people very easily, oh yeah, it is what it is, and let's go, right? Like, and they interrogate the unstructured data. So it's a cultural thing, right? Like, okay, because I can't think of a way to use this in sync with all the other things intuitively and naturally, because it's a sophisticated concept, right? To use it appropriately. I'll just stick to, okay, lab value is this, it says that, so it probably is true, and we don't question that. So I think it's a cultural and like a slightly more nuanced data science culture interaction. That's at least my thought there.
Yeah, I frankly don't see a lot of cultural resistance to using free text data. I see, one thing that I do see is people don't appreciate that free text clinical notes have a component of data quality. I mean, we don't do a good job of acknowledging and trying to classify the data quality in clinical notes. And I would give credit to the radiologists and the pathologists who have done a better job, at structuring their notes in a way that are kind of repeatable. And they did this years ago to make them more readable, more clinically relevant. But the good news is pathology and radiology reports are easier to parse with NLP than free text notes. So one thing that I hope we can do as a country is start putting more emphasis on the quality of a clinical note as opposed to the length and the effect it has on billing and all that kind of thing, right? What's the clinical quality of the note so that we can make it more computable?
Yeah, I mean, as a techie, for me, it's like, let there be variability. How can I build this, like this software so that it takes care of that variability? Let it be easy for the user, as easy as it can be, and let the technology deal with it. That's what the job of the technology is: solve the difficult problem, right? And to me, as a data scientist, if you are able to work with a lot of data, and that was like the thesis of Droice, right? Like that's why you work with so much data. If you have big enough data, you can take care of a lot of these variety problems, and you can deal with it. And
right.
if we didn't have data, like you can create a better standard, and that will help. Of course, it will help, right? Like, but will it ever become close to ideal? No, right? Like human behavior, this is not doctors and like providers. They should not be tasked by like this whole, okay, I have to now do it like this and do it like that. Let them be, and let them focus on the patient. Let the technology in the background take care of it. That's how at least I see technology.
Yeah, I agree, friend. You're kind of prompting me. We'll take one more question, but I also, this is an important book philosophically. This is written by Wittgenstein. He was a 20th century philosopher, probably the most influential 20th century philosopher. And as data scientists and decision makers who deal with humans, philosophically, this book is really good at making you think about the inherent inaccuracies in language and describing the human condition, right? And quite often I think we think that with data we can be more perfect about describing a patient than is truthful. But we communicate to decision makers, we communicate to physicians as if we've nailed the truth. But it's, Plato's allegory of the cave. We don't have the truth, right? And so just kind of acknowledging that uncertainty, I think, because physicians know it's not truthful, but yet we talk to them and we engage with them as if it is the truth, and it's not, right? So anyway, okay, one last question. This is from Connor Petros. The question is, are providers, healthcare organizations more interested in solutions, what comes as a result of high quality data, or the actual data collection itself?
No,
It seems the challenge is convincing people that to have one solutions, you must have the other high quality data. Yeah, I totally agree, Connor. We generally speaking, healthcare decision makers and executives haven't been, nobody teaches these decision makers decision science, right? I mean, I've asked this of my physician friends. I've asked this of, MBAs and MPHs and things that are executive leaders. They've picked up decision making by accident over time, but not by design, not by formality. Yeah.
I think this is the field, right? Like where healthcare is a laggard industry. We all know that, right? And for good reason. In a lot of cases, it's like patient's life at the center. You can't just experiment how you would experiment in the e-commerce, for example.
Right.
And to me, like this data science, this whole idea of like in this new stack that we think like we are bringing to the market, it's just this laggard industry which does not know what is possible. So they don't know what they don't know, right? And then therefore they don't think about what is possible and how we can move from there. Not because they are not smart people or they are not capable people, it's because of the status quo is so inertial, right? Like it's like, okay, if you look at the advantages of this current manual ad hoc process, it's highly scalable. I can hire people who can do ETL. It's infrastructure low, right? Like I don't need a lot of infrastructure. It's only now that like the data from hospitals is moving to the cloud. You look at Europe, it's not even moved to the cloud. It's like starting to move to the cloud, right? So healthcare in general is a very, very, let's say, slow moving industry. And it's this, when you show people that this is possible, it's a supply driven market. When you show that, okay, actually you can like target these patients with better intervention, and actually you can deliver better care, you can get very high quality data, and your research scales infinitely more if you show it to them. Then I think they're like, oh, this is the art of possible. This is possible. Okay, let's go do it. It's cost efficient, it's cheaper, it's better, it's faster, it's more scalable. That is, I think, what we have to show to make this move in the right direction.
Yeah. I'll close with one comment again from my military days. The military thrives on data and data quality and intelligence, right? And all that. We're seeing it play out in the Ukraine right now, sadly. And there's a cultural demand for data quality in the military and national intelligence communities. There's a cultural demand for it. Like if you present nebulous, poor data about a situation to a decision maker, those commanding officers, those political leaders will go back and say, give me better data, right? So there's this thirst for better data that's driven by the mission to succeed. And it includes like the development of sensors and satellites and things like that. It can turn into procurement dollars that says we're going to invest. If you go back to that cartoon that I drew, if you were a military leader trying to understand the patient at the center of that, you would develop a procurement strategy to collect data in each of those categories in the cartoon to close that data gap so that you could execute your mission. But there's not that thirst and there's not that passion yet in healthcare, right? You just don't see healthcare leaders saying, we're going to issue contracts and procurement to round out, and we're going to develop new sensors, right? And we're going to do everything we can to clear up that pixelated image of the patient. Yeah,
I think it's changing. I think it's like this whole changing, and that's, I think, the main point. And the patient deserves it. In my opinion, the patient deserves it, and that's what, at least like how I see this. And like there are enough champions and good people in the healthcare industry who know that the patient deserves it and are fighting for it. And that's how like early adopters, early champions, those are the people who will take this forward and actually make it worthwhile for the patient to get better care. Right?
Yeah.
I really believe that those leaders are there. We just have to show them that it's possible to actually deliver this high quality data for these really important use cases. Even though not incentivized by like the scale, it will come if we make it happen.
I'd like to take a handful of C-levels in healthcare and put them in the Pentagon right now, and let them watch what a passionate, data-driven environment looks like, and put them in the situation room. And all right, friends, well, this is fun. I knew it wouldn't be hard for us to talk. Thank you, and thanks to everyone that joined. And God bless everybody, and be good to one another in an era where there's some harm going on to human beings right now. And let's just keep doing what we can. Jordan, we're all done, friend. Thank you.
All
Thank you,
right.
guys.
Thank you, Mayur. Thank you, Dale. Everyone, have a great rest of your day and please stay safe out there.
Okay. Bye, everybody. Bye, Mayur.
Bye.